How are we going to treat mood disorders? The first thing we start off with is mood stabilizer. This is typically used when we work with individuals with bipolar disorder. What we want to do is we want to shrink that distance, right? Remember the big sweeping lines that the green line made? What we want to do is we want to decrease the high and decrease the low. So we want to narrow everything down to what we referred to as the normative range of behavioral functioning, okay? That normative range is the sweet spot. That's really what we're shooting for with mood stabilizers. Of course, we also treat mood disorders with antidepressants, okay? And back in the day when I was a psychology student, we had 2 antidepressants. Prozac was one of them, and I don't even remember what the other one was. And now we have like so many different antidepressants. It's really varied. The reason why they keep inventing those things is because of the side effects. And then not everybody can take certain things, like certain people, pregnant people, people with different chemistries end up not functioning as well on the meds as they could. And so that's the reason why they keep reinventing. Now they've developed ones that have things like time release, where individuals can take a pill and it'll release over a longer period of time, but at a lower dose, so they're not taking as much. It's just continuously reinvented. And another treatment that is used very, very sparingly, like only in the most extreme situations of major depressive disorder. Remember, that was that orange line that went right across the very bottom of negative affect, is electrical convulsive shock therapy. Okay, that's the ECT. Yes, it was wildly, wickedly popular for a period of time, and I know you guys have read the book, so you know that we've had a really messed up history when it comes to treating disorders. We have put people in asylums, we have done experiments on them. That's one of the reasons why we have an entire board of ethics. Anytime we want to do something, anytime we want to say something's validated or scientifically supported, we have to take it through an internal review board in order to justify our ethics and our treatment of our patients. So electrical convulsive shock therapy really is only now used kind of as a last resort in treating major depressive disorder, even though it gets a hell of a lot more play in movies and media than is actually used in real life. So those first 2, mood stabilizers and electrical convulsive shock therapy, are sort of the biological model, right? Let's treat the chemistry. The idea with the electrical convulsive shock therapy is much like a computer when things are weird and they're not functioning right. If we can do a hard reset, then it reboots everything and allows all the connections to be rewired and set up correctly. Well, the idea with ECT is that because your neurons have both chemical and electrical communication, ECT is working on trying to do a hard restart, for lack of a better analogy, on the electrical part of your neurons' communication. Chemical is what happens between the neurons, and electrical is what happens within the neurons. So the mood stabilizers work between the neurons, ECT works along the neuron, and then it comes to psychotherapy, okay? And the bread and butter, right? And this isn't the best case scenario. We're seeing a lot of advances in therapeutic practice related to mindfulness training. And really so many of the things that we're seeing are kind of a spin-off of cognitive behavioral therapy. Now, if everything about a functioning human being is about thinking, feeling, and behaving, cognitive behavioral therapy is dealing with the behaviors and the thoughts. And so we want to target what you're doing that's not okay. Okay, so let's say you have OCD and you're a checker, which means that you're somebody that is always worried about things being locked or things being turned off or sharp objects being placed away appropriately. And you are a checker in that you find that you are unable to engage in life until you are assured repeatedly that the door is locked. So you check it, and then you check it again, and then you check it again, and then you check it again. And then you get halfway to work and you turn around and drive back and you check it again, okay? Right? Those fit with deviance, distress, and dysfunction because it impairs your life. It keeps you from being able to get work on time. It's distressing because you don't like the behavior. You know that it's not okay. Okay, and it's considered deviant because, you know, in your brain, in your memory, you should be able to know that you lock the door and be good with that, right? And there are some people who will lock the door, take a picture of it with like a selfie of themselves with it, time stamped and everything, and they'll doubt the photo. Okay, they'll doubt the photo. And so for these individuals, we might work with them in treating them. And in this treatment modality, we might say, okay, you're allowed to, how many times do you normally check? And they say, I check the door 7 times. We say, okay, you're allowed to check 6 this week. You can't check any more than 6. Okay, so behaviorally, we're curbing the unnecessary behavior. But then we also deal with the cognitive, with the thoughts. Okay, what could you do? What could you say? What could you create in your environment that would be reassuring for you to know that you actually did lock the door? Okay, so in cognitive behavioral therapy, we're working on both the behavior and the thought. One of the reasons why we're seeing sort of this sort of resurgence of mindfulness is because now we have clinical neuroscience. We have clinical neuroscience, which allows us to study the impact on the brain of meditation and of mindfulness. And we get to see the benefits for individuals. And I have 2 friends of mine. They've been at Columbia, they've been at Harvard. No, wait, they've been at Columbia. Yeah, Columbia, Harvard, and now they're at Vanderbilt. I think they're getting ready to wrap up there and move up to Canada. But they're both cognitive neuroscientists. She's a clinical cognitive scientist, and he is a cognitive neuroscientist. And he gives like PowerPoints to His Holiness the Dalai Lama. It is the most badass thing I've ever heard of in my life. He just like loves it, and I think it's awesome. But his entire agenda is studying monks' brains and understanding how their life course of contemplation, meditation, surrender, detachment in a positive way, not in a defensive way, how all of these spiritual principles that they practice result in them having such amazing health. You know, I mean, that's really at the bottom line is what they have is they have amazing health. They have an amazing longevity, and they also don't have very much disease, cognitive disease specifically. Yeah, psychological disorders. So it's fascinating stuff, and I can imagine that when I'm lecturing about this content, it'll be folded into our book within the next years. I don't know, I'd say 5 years max. And in addition to psychological therapies, I'll have mindfulness training as well. All right. So I wanted to remind you of our 3Ds: deviance, distress, and dysfunction. And then, of course, we always have this danger. And remember, distress could be experienced by the client, right? The individual with the disorder. Distress can be experienced by them. Oftentimes, like we're going to talk about Etta today, she did not have very much awareness of the impact that she was having on her environment. And so her behavior was distressing to others. Okay, her behavior was distressing to others. What I want to do is I told you that we had different sort of classifications of symptoms for schizophrenia. And I want to break them down for you a little bit. We have positive symptoms, we have negative symptoms, and then we have disorganized symptoms. The positive symptoms are what a lot of you touched on, which is the psychosis, which is the delusions and the hallucinations. Now, delusions are the thoughts that I have powers, that people love me, that I'm being persecuted, right? Delusions are those thoughts. Hallucinations are sensory experiences absent of sensory stimuli. So oftentimes individuals who are experiencing a psychotic episode, they can say, I smell my aunt's Chanel No. 5 perfume. And what happens is that when we put these individuals into an MRI machine and we say, are you experiencing any sensory experiences right now? And they can say, yes, I can see my grandma Hattie right now. She's standing right in front of me. And what we see on the brain scan is we see the occipital lobe, right? The part of our brain that's responsible for perceiving sight. And but but there's no change in vision, right? I mean, their eyes are closed, their vision is blocked, there's no change in light, so there's no actual light waves coming in. Similarly, when we have an auditory hallucination, the temporal lobe lights up. Sorry, the temporal lobe on this side lights up, but there's no change in the cilia in the ear, right? There's no change in pressure, right? Sound is conducted by radio waves, right? By auditory waves, pressure changes. And those individuals report hearing things when there's actually been no pressure change to the auditory system at all. So this is where antipsychotic meds come in. We'll talk about the treatment of schizophrenia, but just in case we go a little bit long in the conversation in another direction, I want to point out that when we're treating individuals with psychosis, with delusions and hallucinations, and we use antipsychotics, we run into a side effect called tardive dyskinesia, which are involuntary hand movements. And you're going to see those in this film with Etta here in just a minute. So positive symptoms typically are represented by psychosis, the delusions and the hallucinations. Negative symptoms, this was mentioned by, I think it was Mia. Mia mentioned alogia. And this is not speaking, okay? Positive symptoms means there's something that is divergent that is added to the environment, right? Delusions and hallucinations. Negative symptoms are behaviors and thought processes and feelings that are removed from normal practices. So when I think about positive symptoms, I think of sort of normal things blown out of proportion. And when I think of negative symptoms, I think of normal things that have been removed. In our culture, unless you have like a structural impairment or there's another issue with you anatomically, you're going to be a talker. You're going to speak. Like if you're of a certain age and ability, you're going to talk. So not having speech is pretty significant. The other thing that we see is flat affect with individuals who have schizophrenia. And the people that were in my group mentioned catatonic states. And catatonic states, there's definitely alogia. And when and if they do speak, their affect is really super flat and totally monotone. True story, and when I used to teach abnormal psychology, I would come in on the night of schizophrenia and I would act schizophrenic, like I would represent the symptoms and I would have the students try to figure it out. And then thank the heavens, we got clinical videos. But I had students that were so concerned about me, you know, I mean, because I'm a pretty dynamic, I have varied affect, but I would come in and I would try to speak in a monotone, and I'd never made it very long at all. Other negative symptoms that we see, anhedonia, which is something that we also see in depressive states. It basically means a lack of pleasure, a lack of joy, an absence of positivity. And so that's another negative symptom. Some disorganized symptoms, and this is just a little bit of a catch-all, and this is when it's not the presence of something aberrant, it's not the absence of something normal, it is very clearly something that is not following the linear expectation of our culture. So when I talk about disorganized language, this could be what we call word salad, where individuals just say words and connect them when logically they make no sense. They're literally just a salad. Words are just thrown together. There's really no association that we can see between them. We also have tangentiality, where an individual could be asked a specific question and they can just go off on a tangent. Now, I know lots of people, including myself, that can go off on tangents for days. That does not mean that we're schizophrenic. That is just part of it. And they're incredibly, incredibly incoherent. And the other sort of catch-all with disorganized symptoms is affect and behavior. So an individual would have disorganized symptoms affectively if they were at a funeral and they made a joke of it. Okay, that would definitely be a red flag of sorts. And then behaviorally, they would do things that seem nonsensical. And I think culturally, one of the iconic behaviors is wrapping your head in aluminum foil. All right. What I want you to do is I want you to keep in mind the positive, negative, and disorganized symptoms, and we are going to watch some of Etta. Remember to be mindful and respectful in the chat. Be aware of your language. It's really important that we don't use any degrading terminology, because I'll guarantee you, statistically speaking, out of 203 people in this class, we have at least 25 people in here whose lives are impacted by schizophrenia. So please keep that in mind and be respectful. And that is not where I wanted to go. Play this video.
Suffers in a profound way from schizophrenia. Schizophrenia is one of the most severe mental disorders. It's usually a lifelong disorder with periods of psychosis. In some cases, like Etta's, these periods of psychosis can go on uninterrupted for years. Also notice that in Etta's case, her disorganization of thinking is so profound, it makes it difficult to ask about other symptoms.
I want to thank you for coming down this morning, and you and I have had plenty of chance to have conversations before, but this is our first one on video. What went on that you ended up coming into the hospital?
Well, Jesus was giving me all these window crack and screen crack sounds, telling me that they was going to break into the house. So I put the camera stereo in the room where they chiseled the window out to come through the window.
Mm-hmm.
And the camera stereo, the security guards picked that up, the message, by putting that camera in that room.
Mm-hmm. Were you in danger?
Well, if anyone gets into the house, they said I get shot.
Who said?
That's the Eagle.
Can you say a little something about the Eagle?
Well, the Eagle works through General Motors. They have something to do with my General Motors check I get every month.
Mm-hmm. And you get that check because it's part of your husband's work with GM?
Yes.
Say something more about the relationship between GM and the Eagle.
Well, when you do the 25 of the clock, it means that you leave the house 25 after 1 to mail letters, so that they can check on you, how you're mailing the mail, and they know where you're at that time.
And who's they?
That's the Eagle.
Okay. And is the Eagle something that is looking out after you, or is there a chance that the Eagle could hurt you?
Well, they're the before on the clock. That's the 6, 7, 8, 9, 10, 11, 12, 1, 2, and 3. They go by those numbers of the clock.
Mm-hmm.
And when you do the 25 after, that's the after side of the clock. We go by the 1, 2, 3, 4, and 5 of the clock.
Mm-hmm.
And the 5, you go right, left to 7 number on the clock is the fire number. You go right, left to that number.
Mm-hmm.
That's what the 25 is. If you don't do something they tell you to do, and Jesus makes the shotgun sound, and then the phone rang, not to answer the phone or the doorbell.
Why not?
Because you get shot.
Who would do the shooting?
The Eagle.
Now, I remember when you first came in, were you seeing some visions on the floor?
No, I was just confused. At first they didn't tell me why I was in there.
Mm-hmm.
But the security guards came and they were very nice to me. I wasn't handcuffed.
Can you say more about the things that were happening at home?
Well, when Jesus made the shotgun sound and then the phone rang, not to answer the phone or the doorbell, I knew it was Jesus talking to me. And he floated. I seen a Kmart bag float down from my ceiling to the floor. That's probably what you was thinking about.
Yeah, no, tell me about that.
Well, he made the sound of the bag opening up,
Mm-hmm.
And I had my back turned to the bag, and I was sleeping. And when I heard the bag open, Jesus wanted me to look at the Kmart bag floating down from the ceiling to the floor.
I'm wondering, though, whether these kinds of experiences that you have are really unique to you, whether there's something special about your relationship with Jesus, or whether this is the kind of relationship that other people may be having too.
Well,
What's your personal feeling about that?
well, I'm not. I don't like to judge anybody.
I know I'm asking you a tough question.